This presentation is about Delirium, made by Sally Naim. This is a short video covering 3 objectives. By the end of this presentation, you should be able to identify signs and symptoms of delirium and the 3 subtypes, discuss common precipitating factors of delirium in the hospital setting, and explain the effects of delirium on patient outcomes in critically ill patients. As defined by the DSM-5, delirium is an acute neuropsychiatric disorder characterized by disturbed level of consciousness with reduced ability to direct, focus, sustain, or shift attention, as well as other cognitive disruptions, such as altered psychomotor functioning, emotional dysregulation, circadian rhythm dysregulation, attentional deficits, and cognitive deficits. This disruption of normal neuronal activity is secondary to systemic disturbances leading to acute brain failure. In other words, delirium is a severe state of confusion. It fluctuates throughout the day over a short period of time, lasting hours to several days, in which delirious patients cannot think clearly, they have trouble paying attention, they have a hard time understanding what's going on around them, and they have hallucinations where they hear and see things that aren't there but they believe it's true. Is delirium serious, you ask? It's very serious. Delirium is the most common psychiatric syndrome found in about 1/3 of older individuals during their hospital stay and found in about 2/3 of ICU patients. Others say delirium has an incidence as high as 87% in the acute care setting. It is estimated that delirium goes unnoticed by healthcare providers in 30 to 79% of cases. This is because delirium can affect people of any age, color, and gender, and it appears in unusual forms organized into 3 subtypes. The first subtype we're going to discuss is hypoactive delirium, and this subtype is associated with symptoms of a flat affect, apathy, lethargy, withdrawal, somnolence, and decreased responsiveness. Hypoactive delirium is the most common and is also associated with a poor prognosis, as it is potentially less frequently recognized or it is dismissed by healthcare providers. The second is hyperactive delirium. This subtype is associated with signs of heightened arousal and may result in agitation, restlessness, combativeness, emotional lability, hallucinations, and delusions. And unlike hypoactive delirium, hyperactive delirium is less common and only represents 1/4 of cases. The third is mixed subtypes. Obviously, from the name, it is associated with fluctuations between both hypoactive and hyperactive delirium. So now that we've covered the definitions and the signs and symptoms of the 3 subtypes, it's time to figure out what causes delirium. Delirium is known to be typically multifactorial, and so it has several precipitating factors, like dehydration or electrolyte abnormalities, including volume overload or a changed pH. Changing the setting of an individual that they're most familiar to, such as being admitted to the hospital or ICU setting, can also be a factor, as well as having glasses or a hearing aid that aren't being used. Hypoxia are stressors. That means, do they show signs of hypoxemia? Does the patient have sleep issues, pain, or fever? Or do they have fecal or urinary retention? Is the patient having mobility issues? Are they confined to the bed or are they restrained? Does the patient have an illness or illnesses? Do they have an infection and are they being treated for it? One of the most common precipitating factors are drugs, whether it's polypharmacy or withdrawal. Benzodiazepines are the most dangerous, but other drugs such as narcotics, anticholinergics, beta blockers, steroids, and others can also cause delirium. Withdrawal states, such as alcohol withdrawal or benzodiazepine withdrawal, can also be contributing factors. And even though we mentioned that all ages are at risk, older ages, especially those with comorbidities, are at even higher risk. Now, there are several ways to remember this, like through the use of mnemonics. THINK. Think, toxic situations, like CHF, shock, dehydration, deliriogenic meds, new organ failure such as liver or kidney. Think hypoxemia, infection or immobility. Can they exercise, get out of bed, ambulate, or are they restrained? Think about non-pharmacologic. Think of hearing aids, glasses, reorient them, play music they like, keep noise at a minimum, and develop sleep protocols. Some of the earliest signs of delirium are abnormal sleep-wake cycles, like sleeping in the day and waking up at night. Think of potassium imbalances or think of electrolyte problems. Another mnemonic is delirium. This stands for drugs, environmental factors, low oxygen, infection, retention, immobility, underhydration, and undernutrition, as well as metabolic causes. Everything we've already mentioned. Any mnemonic is worth using since there are way too many factors to remember, and you can use whichever you like or even make up your own, as long as it helps you remember factors causing delirium. Now that we've covered the precipitating factors, what happens if delirium goes untreated? Delirium consequences can be detrimental. Even though this is an acute problem that goes away after several days, it can still be associated with long term outcomes. This includes increased mortality and morbidity, increased cost of care, longer hospital stays and hospital infections, which thereby decrease the rate of recovery and quality of life for patients. But that's not all. Delirium is also associated with poor functional and cognitive recovery, which can be quite severe at the time of hospital discharge. Cognitive impairments improve slightly over time until stabilizing or reaching a plateau, but cognitive impairment rarely returns to premorbid levels of functioning, thereby forcing patients to rely on a caregiver. Evidence suggests that cognitive functioning in ICU survivors occurs in wide-ranging domains, including memory, attention, executive dysfunction, and processing speed. Survivors of critical illness can have significant real world consequences like difficulties returning to work, balancing a checkbook, finding a parked car, following a simple recipe, or managing medications or medical devices that they are once used to, and difficulties driving. This reliance on others can lead to development of depression in about a quarter to a third of individuals. It can lead to anxiety or even PTSD, which occurs in about a tenth to a third of critical illness survivors. The existence of psychiatric syndromes, specifically combined with cognitive impairment, usually results in a diminished quality of life. In conclusion to this short video, the best way to treat delirium is to prevent delirium from happening at all. Thank you for watching, everyone.